Hey everyone, welcome back to Patho-Mnemonic. This is an NBME Shelf Exam and Step 2 CK content review series. In this episode, I'll be going over some high yield surgery, trauma surgery type stuff for those of you who are studying for your surgery shelf or studying for surgery questions on Step 2 CK. This episode I feel like is going to be pretty dense, so I'm just going to go ahead and get right into it. Um, I will start with some head injuries and we'll go from there. So, um, the next step in management with head trauma resulting in a loss of consciousness is you want to get a non-contrast head CT to rule out hemorrhage. Um, and we will see some examples of head trauma that results in a hemorrhage, and then we'll get into that. But this is the first step that you want to do. If someone comes into the emergency department and they like got hit in the head, had a loss of consciousness, the vignette will be like, "What is your next best step in management? You want to get a non-con head CT." Some other high yield information about head injuries um, involve monitoring for signs of elevated intracranial pressure or ICP. Those are papilledema, projectile vomiting, a pounding headache, and then you'll see a triad of things called Cushing's triad, which includes irregular respirations, bradycardia or a slow pulse, or and hypertension or a high blood pressure. So these three things are Cushing's triad, which basically happens when, let's say, for example, someone gets head trauma and they have a hemorrhage, or they have like a brain cancer, or anything that's causing elevated intracranial pressure. Um, that intracranial pressure presses on the respiratory center, which gives you irregular respirations. Um, Also, because the skull is like a closed container, while either blood or brain parenchyma is increasing in volume and pressing on all of the arteries and veins and stuff in the brain, um, blood pressure increases in order to kind of maintain cerebral perfusion pressure. Um, but since this is happening kind of systemically, that elevated blood pressure also stimulates or affects the heart, um, and ultimately results in a reduction in heart rate to like maintain a normal cardiac output. So irregular respirations, bradycardia, slow pulse, and high blood pressure are like really high yield features of Cushing's triad. How do you manage someone that has elevated intracranial pressure? You can do a couple of things. One of them, non-invasively, you can just elevate the head of the bed. Um, you can also give mannitol or furosemide to take some fluid off. Um, and then you can, if the patient is intubated, you can hyperventilate them. Okay. Some other head trauma stuff. You'll also be asked about signs of a basilar skull fracture, or you'll see like features of a basilar skull fracture. Those are like if they have clear fluid draining from the nose or from the ears, if they have these like periorbital ecchymosis or bruising around the eyes, or like colloquially, they look like raccoon eyes, or if someone has posterior auricular bruising, all of these features can indicate that there's a basilar skull fracture. Um, on the topic of skull fractures, how do you manage a closed, non-displaced skull fracture? So, like if someone has head trauma, they come into the emergency department, they get a non-contrast head CT, or maybe they just got an X-ray because they didn't lose consciousness. But in either case, you see a skull fracture, but it's closed, as in it hasn't like broken through the skin, um, and it's non-displaced, so there's like no gross visible deformity. That's just conservative management. Um, if there are other things going on, like let's say, for example, they have a closed, non-displaced skull fracture, but they have like this massive hemorrhage, obviously you would manage the hemorrhage and not just be like, yeah, you'll be okay. But like the management specifically of the closed, non-displaced skull fracture is just conservative management. Contrast that with someone who comes into the emergency department or wherever, and they have an open skull fracture. So obviously it's displaced, and to the point at which it's like broken through the skin. Um, so this management is kind of broken up into three things: antibiotics, surgery to fix the fracture, and then afterwards you give them seizure prophylaxis like phenytoin. Um, and the funny way that I remember the management of an open skull fracture is ASS. So an open skull fracture is ASS. Um, Antibiotics, just because it's open, it's broken through the skin, and so it's exposed to the environment, and all those bacteria can get in there and not be good. Surgery for obvious reasons, and then seizure prophylaxis because it's usually a big enough trauma to upset the brain and can cause seizures. So that's management of an open skull fracture. Okay. Um, there are going to be a lot of images in this episode and in like subsequent surgery episodes. In general, I'll say like the surgery shelf and surgery questions on step 2CK aren't going to ask you specifically about like surgical methods, as in like, oh, what step in this specific procedure do you do? Or like, what procedure do you do? It's more like ultimately it's recognizing who is sick and needs surgery now, who is sick and can have surgery later, or who is like sick and doesn't need surgery, and who is like not sick and therefore does not need surgery. Um, Not necessarily like what artery. Well, I won't elaborate on that too much, but we will also in surgery questions, you'll see like a lot of images because surgery questions and all that other stuff love to give you images and ask you how to interpret them. So anyway, continuing with head injuries, there's like an elderly person or like a newborn baby who just went home, um, and they have this like minor head trauma. Um, but they come into the office or they come into the emergency department because over the past couple of weeks, whoever's been taking care of the patient at home or at like a nursing home or whatever they've noticed like progressive neurological deficits. So they're like sleepier than normal. They're like not acting the same. They might have hemiparesis or hemisensory deficits. They might have nausea or vomiting. You get a non-contrast head CT, and it shows unilateral crescent-shaped hypo or hyperdensities. And so I found an image that actually includes both. So if we look at this head CT, there's a hypodensity here, and then it's a hyperdensity here, and it's like this crescent-shaped lesion. So what is the diagnosis in this case? This is a subdural hematoma. Um, and we will see other kinds of hematomas. Don't you worry. What are the affected vessels in a subdural hematoma? These are the bridging veins. And then what's the difference between a hypodense or a hyperdense crescent-shaped lesion on the CT? So a hypodense indicates old blood, which is like leaked out through the bridging veins and is like coagulated and is now just like chilling there. Um, if it's hyperdense, that means it's acute blood or the bleed is like still going on or there's like more recent injury. Why is it a bimodal age distribution? Like, why is it old people or babies, not necessarily like teenagers or middle-aged adults or whatever? Um, just anatomically or physiologically or whatever, age extremes have weak bridging veins. So they're at high risk for subdural hematomas. In the case of elderly people, it's like as they get older, their brain parenchyma can like shrink a little bit, and then that shrunken brain parenchyma kind of reduces the amount of tissue that's in the skull, and so then it can kind of like put some additional tension on the bridging veins, and then any minor head trauma can like shear the bridging veins, and then voila, you have a subdural hematoma. What is the management of a subdural hematoma? You check for midline shift. If there's midline shift, then that's an indication for drainage. Um, if there's no midline shift, then you're pretty safe to manage and monitor any signs of elevated intracranial pressure, which we were just talking about. So in this case, this example of a CT, Yes, there's a subdural hematoma and it has hyper and hypodense blood, but there's no midline shift. Like the brain parenchyma, the hemispheres are like largely contained within their respective sides. And so this is probably not too concerning of a subdural hematoma. But if you are noticing a midline shift away from the subdural hematoma, usually they'll also present with more severe neurologic deficits. Um, but you'll also see like the imaging findings consistent with midline shift. And so in that case, you would want to go in and drain it. That is to say, again, if there's not midline shift, then you don't necessarily need to immediately go in and drain it. So again, surgery versus not surgery. Take a look at this non-contrast head CT, which is a little bit different from the last one. Um, you'll see this in the context of a patient who had head trauma, and then they may or may not have lost consciousness initially, like after the head trauma. And if they did lose consciousness, they wake up, they're totally fine, they're totally with it, and then they're going to the ER, or maybe they just go home or they're going about their day because they're like, oh, I hit my head and I'm fine now. In any case, they become nauseous, maybe they vomit, they become more lethargic, and then either on their, once they get to the ED or like if they get home or something like that, they're like comatose. They've like passed out, not with it. You do a neurologic exam. They have a sluggish pupil. They have irregular respirations. They have left-sided hemiparesis. You do a non-contrast head CT, and you see a left unilateral lens-shaped hyperdensity, which is what we're seeing here in this non-con head CT. Um, One quick comment that I'll make is like, since this patient is comatose on arrival, you can't like ask them to get out of bed and like assess their motor strength. So one thing that you could try is like you could look for posturing, or you could look for like how strongly they withdraw their extremities to noxious stimulation. So you can make somewhat of an assessment of their motor strength, even if they're comatose. So what is the diagnosis of this patient? This is an epidural hematoma. So it's like the lens-shaped or the football-shaped hyperdensity. What are the affected vessels in an epidural hematoma? These are the middle meningeal arteries, as opposed to the bridging veins that we saw in a subdural hematoma. So these are arteries, whereas the last one we were talking about veins. So if you rupture or shear an artery, those have significantly higher blood pressure, and so then you get this really quick accumulation of blood. What is the cause of the ipsilateral hemiparesis? So like, maybe in surgery, but also applicable to neurology, shelf or step questions. Um, You'll see this like you'll have to localize the lesion in the brain. And usually, like if you have a left-sided lesion in the brain, you would have right-sided deficits, right? Because it's like the sensory and motor stuff decussate before getting to their corresponding extremities or whatever. Unless if it's the cranial nerves, but I'm not talking about that here. So you have ipsilateral hemiparesis, left-sided hemiparesis, and there's like this left-sided hyperdensity. Whereas normally, like if this was a left-sided lesion, you would expect to see right-sided hemiparesis. But in this case, because of the ipsilateral hemiparesis, this is an indication that there was herniation from the increased ICP of the contralateral crus cerebri against the tentorial edge, which is like a lot of big words, but basically it's like the motor fibers that are originating in the right um, motor cortex, as they're going, as they're descending, they get to the crus cerebri and they decussate to the left side where they ultimately control the left extremities. But if there's herniation of parenchyma against the tentorial edge or like part of the skull, there's compression of those fibers. And so then they're not working. And so then you get um, compression of the motor fibers that control that. So this is like pretty severe. Um, I wanted to make one other comment, but I'm not remembering what it was. Maybe I'll remember it as I keep going. Oh, maybe not. Um, No, we'll get to other stuff that'll answer that question. Okay. So speaking of herniation, there are also a lot of different types of herniation. Oh, I remember what I was going to say. So another hallmark feature of epidural hematomas, um, I wouldn't necessarily use it as like the diagnostic feature if I'm trying to make the difference, or if I'm trying to differentiate between two different possible answers per se on a multiple choice test. But one thing that leads me in the direction of an epidural hematoma is that like lucid interval where it's like you get the head trauma and then they might not lose consciousness, or if they do lose consciousness, they come right back and they're like with it, and then they decompensate and then they really, go downhill. For some reason, that shows up a lot in epidural hematomas. Perhaps it's because like, the initial injury is may or may not be enough to knock them unconscious. And if it's not, then like, whatever. But like that's also when the blood starts leaking out of the middle meningeal arteries. And so before all of this blood accumulates, everything else in the brain is fine. So they're, neurologically intact. But then as the blood continues to accumulate really rapidly because this is an arterial injury, then once you have high enough ICP, that's when you start decompensating and then have these all of these other neurologic deficits and symptoms. Okay. So speaking of herniation, what's going on in each of the following? So if someone comes in head trauma and they have unilateral leg weakness, that's an indication of subfalcine herniation, which is where the cingulate gyrus herniates under the falx cerebri and it compresses the anterior cerebral artery. So if you remember the homunculus, where it's like the way I remember it is like the feet are like relaxing on the edge of the hemispheres and they're like dipping into the falx cerebri or whatever. But like that's supplied by the ACA. So if there's compression of the ACA, then you have neurologic deficits of like the motor strip that's controlling the lower extremities. And so then that can cause unilateral leg weakness. If you have mydriasis or like a dilated pupil, um, let's see, ptosis and a down and out pupil, that is a transtentorial or an uncal herniation in which the ipsilateral cranial nerve 3 is compressed. Um, and oh no, I'm sorry. Mydriasis is it's not a dilated pupil, it's a constricted pupil. My bad. No, it is dilated. Just kidding. Yeah, it's dilated. Meiosis is the constricted pupil. Mydriasis is a dilated pupil. Anyway, a dilated pupil, you have ptosis or like drooping of the eyelids, and then it's the pupil is down and out. Um, you have cranial nerve 3 compression, which results in unopposed cranial nerve 4 and cranial nerve 6 action. So if you remember, these are the nerves that control the eyes. Um, so nerve by nerve, we'll go like the functional deficit. So if you have compression of cranial nerve 3, that's the oculomotor cranial nerve. So cranial nerve 3 isn't working. And so like most of the extraocular movements are impaired. Cranial nerve 3 also controls the um, constriction of the pupil. And so if you aren't getting any neurologic, if you're not getting any signaling from cranial nerve 3, not only are you impairing the extraocular movements, but you're also not getting any um, stimulation to constrict the eye. And so as a result, you get a dilated pupil or mydriasis. Um, the other cranial nerve, the other cranial nerves that control the extraocular movements are cranial nerve 4, which ultimately um, kind of like turns the eye down. And then cranial nerve 6 or the abducens um, abducts the eye. And so if you have unopposed cranial nerve 4 and cranial nerve 6 function, you have an eye that turns down and turns out. Um, if you have contralateral homonymous hemianopia with macular sparing, that is an indication of, again, of transtentorial or uncal herniation, in which the PCA is compressed, and that supplies the visual cortex. So compression of the PCA leads to visual cortex ischemia. And then the reason why you have macular sparing um, is because the cortex, the part of the cortex that corresponds to the macula, is supplied by the PCA and the MCA. So even if you're compressing the PCA, the cortex that's getting information from the macula is still getting supplied by the MCA. So it's still like alive and working okay. So you'll have vision in the macula. If you have someone who is like altered mental status or they're comatose, that usually means that there's again transtentorial or uncal herniation um, because of compression of the reticular formation. So like this is pretty bad. Um, if there is impaired consciousness and there's extensor posturing with flexed wrists, that is tonsillar herniation through the foramen magnum. Okay, so lots of different types of cerebral herniations and like different ways to go about them. But the more you practice and like the more you see it, the easier it is to recognize. One other comment that I'll make about posturing is you'll also see like decorticate or decerebrate posturing. Decorticate is flexure posturing, and then decerebrate posturing is when they're extensor. And usually, like extensor posturing is significantly, well, extensor posturing or decerebrate is worse, or it's like a sign of a lower injury to the brain or like further down the brainstem because that's that has to do with like the red nuclei in the pons, which like you don't really need to know in the case of shells and step. But one thing to know is that extensor posturing is worse um, than flexure posturing. Anyway, so another question that they might ask you is like someone's in the ICU and they're like still intubated, still sedated, and then the family is at bedside and they're asking you like about what their prognosis is, or in any way you have to like remember the criteria for brain death. For some reason, is a pretty, I guess for good reason, it's a criteria that continues to show up on NBME exams. Those are three things. There's a known cause of coma, and then you've effectively excluded or treated all of the reversible causes of coma, and they're still comatose. Um, Number two is if there's a lack of brainstem reflexes and there's a lack of like a response to pain. So like if you give noxious stim and they're not doing anything, and you do like the caloric water testing and they're not responding at all, um, or all of the other brain, like if they don't have a gag reflex, um, that's an indication or that meets the second criteria for brain death. Um, Another thing to look for is an apnea test. So like if they're um, maybe not intubated because they're already getting respiratory rate, but in any case, like if you ultimately the apnea test is to assess for an increase in respiratory rate if there's an increase in their CO2. And if that's not happening, then they've like failed the apnea test. And so that's like meeting the criteria for brain death. So usually it's like they're meeting like one or like two of these criteria for brain death, and then it's like which of the following needs to be proven to diagnose brain death, and then it's like one of these other options, or all of them are there, and then like the family's like, what else can we do to make a clear diagnosis of brain death? So like if all of these are met, but there's still uncertainty, you can confirm or push the arrow towards brain death with cerebral blood flow studies. So like cerebral angiography, transcranial ultrasound, CT or MRA, or a radionuclide scan. Like one of these options can help make the diagnosis of brain death. Like these questions can kind of be a little confusing, but it just like knowing these basic things will get you to answer them right. Okay, so we will go from the head to the chest. And again, we will see a lot of images or x-rays and stuff like that. So lots of vignettes as well. So, I mean, because that's how these questions work. So a man comes to the emergency department after falling while skiing at a high speed. He complains of chest pain that is worse on inspiration. Vitals are stable. Physical exam shows just localized tenderness of the left lateral chest wall. They get a chest X-ray, and it shows this. What is the most likely diagnosis? You might, I mean, it's kind of hard to pick out, but like if you kind of think localized tenderness of the left side, so there's something on the left side. Um, I'll stop waiting. This is a rib fracture. Um, what is the next step in the management of just one rib fracture? It's usually conservative management, like over-the-counter pain meds, rest, ice, stuff like that. Not surgery, so surgery versus not surgery. What if the patient was an elderly man who fell while at home instead of this like skier? Um, in this case, you would want to consider a local nerve block and incentive spirometry. Like if it's a more severe or like a frail patient who has a rib fracture, this is you want to do a little bit more. And the reason why you want to do that is because it's associated, like the pain from the rib fracture, and it's worse when they inhale. So then, because there's pain and they're inhaling, they won't inhale as well. So then you can get hypoventilation, which can collapse the lung, cause atelectasis, and then that can be like a breeding ground for bacteria to cause a pneumonia. And obviously that would make things so much worse. So if you get rid of the pain, then you don't have to worry about hypoventilation. And then this little thing right here, this is the rib fracture that I circled in case you missed it when you were looking at it the first time. Okay, here's another chest X-ray, more chest trauma. A man is brought to the emergency department by ambulance after a high-speed motor vehicle collision. Patient was unrestrained. Patient is groaning in pain. The trachea is midline. Pulses are intact in all extremities. Vitals are stable. And then you're watching the patient, and you notice that while they're inhaling, a segment of the patient's right chest caves in, and then when they exhale, it bulges out. Chest X-ray is shown. What is the most likely diagnosis in this case? This is a flail chest or like multiple, it's like, I think it was multiple rib fractures in multiple places makes this like little segment of ribs that can like cause this paradoxical chest wall motion. And that's circled here. The management of flail chest we will get to in this next vignette. So very similar patient, high-speed motor vehicle collision. They have chest pain. They have an irregular heart rate, but otherwise they're very sta or they're vitally stable. And then you do clinical and imaging findings, and they're consistent with a flail chest as well. So we've already made the diagnosis of a flail chest, but they also have this irregular heart rate. This is caused by a blunt cardiac injury. Another thing that you'll see like on EKG, or so for blunt cardiac injury, you can see irregular stuff on like the EKG, and they'll also have elevated troponins, um, which is like a sign of myocardial injury. What is the management of someone with this stuff, the blunt cardiac injury and the flail chest? Really, still, this might look pretty severe to you right now, but it's not surgery just yet. So again, recurring theme of surgery versus not surgery. Um, so far, we actually haven't seen a whole lot of surgery. In any case, monitoring and treatment of the arrhythmias. So like you'll put them on telemetry, you get an EKG, and if they have an arrhythmia, then you would treat it as necessary. Um, and then supportive care. So let's say like the next day, so the patient's obviously in the hospital, and then like the next day, the patient, you notice that they're short of breath and they're confused. So they've changed clinically. Um, a lab that you would want to get for this kind of patient, you want to get their blood gases. Because in settings like these, confusion is often an indicator of hypoxia or low PaO2. Um, especially in so you would kind of go down this route because of the flail chest and all this other injury to the chest and the lungs. So they're not oxygenating well enough. And so they have a low PaO2 and they can be confused. What imaging would you want to get? You would, even though you got a chest x-ray the first time, you could get a chest x-ray again. And on that chest x-ray, this time you might see bilateral whiteout or like radiopaque, fluffy bilateral infiltrates. Um, so the diagnosis in this case is a pulmonary contusion after the chest trauma. So, like I said, how do you manage pulmonary contusion in the setting of a flail chest? Still, you do supportive care and supplemental O2 as needed. Um, and if they're really not looking too good, you would consider fluid restriction and diuretics because flail chest and, well, not flail chest, pulmonary contusion is very sensitive to fluid status. And so you want to restrict fluids and diuretics to prevent all that fluid overload. Um, so the flail chest itself doesn't necessarily need too much management, but flail chest is usually associated. You would want to look or monitor for pulmonary contusion, in which case you would need to do a little bit more. Okay, spoiler alert, we're seeing an EKG, so we're probably going to talk something cardiac. Um, so chest trauma, and then the patient comes into the ED and they're tachycardic. Their blood pressure is 70 over 30, which is not good. Extremities are cold, pulses are feeble, heart sounds are muffled, jugular venous distension is elevated. EKG shows QRS complexes with alternating amplitude, which you see down here. Um, which is, what's the diagnosis and how do you manage it? This is pericardial tamponade. The features in this vignette or associated features in pericardial tamponade physiology, you can describe it with Beck's triad, which is a pretty high yield feature or high yield constellation of hypotension, e- elevated JVD, and muffled heart sounds. Um, which we all see in all three of those you see in this vignette. Another thing, actually, so it's you'll see, I mean, this is a medicine or medical doctor test, so you're obviously going to see a lot of blood pressures. And sometimes it's hard to determine if a patient is hypotensive or not. And I've said this in a lot of other episodes, but I'll reiterate it here. My magical cutoff for blood pressure indicating hypotension is if they're less than systolic 90 over diastolic 60. So this patient is obviously hypotensive because they're less than 90 over 60. Um, anyway, so the management of pericardial tamponade, you immediately go to a pericardiocentesis. You want to drain that fluid from the pericardial sac immediately. Um, you might also be tempted to get an echocardiogram, like they'll give you that option on the multiple choice test, but you only get an echocardiogram if the clinical diagnosis is unclear. So if this is a slam dunk diagnosis of pericardial tamponade, so you do not need to get an echo. You can just go straight to pericardiocentesis. Um, and that's just because, well, I guess a brief aside to talk about like the um, physiology of the pericardial tamponade. You have either blood or fluid or something that's leaking into the space between the pericardium and the heart itself. And since there's so much fluid accumulating in there, um, there's not enough room for the heart to expand. So then, preload drops off. Um, so then cardiac output goes downhill. So you get tachycardia because of hypotension, because there's not enough fluid entering the heart, and therefore there's not enough fluid leaving the heart. So hypotension, and because of the hypotension, that stimulates tachycardia. Um, and then the heart sounds are muffled because of the fluid that gets in the way. So let's say there's a patient that has pericardial tamponade, they get a pericardiocentesis and they're fine, and then this happens again and again and again. Um, the management of this patient with recurrent pericardial effusions, which can cause tamponade, um, or maybe it's not enough to cause pericardial tamponade, but they still get it drained anyways. You want to get a pericardial window uh, to like give a like an out. You want to give like a drain, basically, not like an external drain per se, but like you want to prevent that fluid from uh, accumulating in the pericardial sac. You also want to find and treat the underlying causes of recurrent pericardial effusions, because these don't just like happen on their own. There's usually some underlying pathologic cause, which include things like cancer, tuberculosis, lupus, or rheumatoid arthritis. Um, so you'll want to keep your eye out for this kind of stuff on a shelf exam or on a step two exam question. And then this EKG down here, this is what the vignette was showing, the EKG showing QRS complexes with alternating amplitude. This is electrical alternans, which is basically like the heart is swinging around in this extra fluid in the pericardial sac. So like sometimes when it beats, it's close to the EKG lead, and so you have a higher deflection. And then sometimes it's beating when it's a little bit further away from the EKG lead, and so then it has a smaller QRS complex, and then it goes back and forth. Okay. Another very high yield kind of question that you'll see on surgery, maybe internal medicine, um, and ultimately on step two as well, is indications to intubate. Um, so, you'll probably hear the whole like GCS less than 8 means you need to intubate. Um, so you can follow that rule and like assess a patient's GCS score. Um, Or ultimately, the more important like clinical features for indications to intubate someone ultimately means that there's airway compromise, or an inability for a patient to protect their airway. So I'll get to GCS scores at some point, but I'm going to talk more about these airway compromise things. Um, so a list of those include things like a neck injury with an expanding hematoma. So like if someone comes in and they got like stabbed in the neck or something like that, and you see them when they first come in and they had this little hematoma in the neck, and then like you come back a couple minutes later and it's bigger and it's bigger and it's bigger. That's an indication to intubate because that hematoma can compress the airway and not be good. You want to intubate them before it occludes or like closes off their airway. Another indication to intubate includes severe inhalation injury. So, in the setting of like a vignette, there will be a patient that was in a house fire, and then they come into the emergency room, and you look in their mouth, and it's like black with soot. That is another indication for airway compromise. Um, Another possible indication for intubation is like really bad anaphylaxis or anaphylactic shock, because like all of that swelling can occlude the airway. If someone has neck trauma, so similar to the expanding hematoma, but like, you listen to them and they're coughing and they have these like really gurgling sounds. In that case, that's an indication for intubation because there's like, maybe they're bleeding into their airway. Um, and that's what's causing them to cough and make all these like weird gurgly breathing sounds. Um, Another indication for intubation includes subcutaneous emphysema after trauma. So, they have like neck or chest trauma. You do a physical exam on them and they have like that crepitus like right around um, the clavicles. That indicates tracheobronchial injury. Obviously, like you wouldn't just make this like if anyone comes into the emergency room and they have subcutaneous emphysema, that by itself is not an indication to intubate. Like I've seen kids that have pneumomediastinum in the setting of an asthma attack, and they have subcutaneous emphysema. They were not intubated. But if they have like really serious trauma, you get a chest X-ray and you see like tracheobronchial injury and they have subcutaneous emphysema, that's when you would want to intubate. So it's like really serious. So if they have tracheobronchial injury causing subcutaneous emphysema and then like they had trauma, not only do you want to intubate them, but you want to be really careful about intubating with a fiber optic bronchoscopy because this like tracheobronchial tree is injured and you just like shove the blade down their airway, like, I mean, it's already injured. So you want to be very careful and like visualize the structures really well. All right. So we will continue with some more chest injuries. Um, Here's another chest x-ray. Patient comes into the emergency room after a high-speed motor vehicle collision. Patient was the unrestrained passenger. This is like your eyes will glaze over when you read this stuff on the shelf for the step exams. Um, Temperature is 37.5, heart rate is 110, blood pressure is 130 over 85, respiratory rate is 26. The patient is in respiratory distress. You do a physical exam and they have decreased breath sounds on the right. And then you get a chest x-ray and it is shown here. What is the most likely diagnosis in this case? This is a pneumothorax. So you can see it here. Like you can see, hopefully you can make it out on the video, but this is the edge of the lung parenchyma itself, and then like here's the edge of the chest wall, and there's like this free radiolucent kind of distance between the chest wall and the end of the lung parenchyma, which is air, therefore pneumothorax. Findings on a physical exam of like an uncomplicated pneumothorax, they'll have a midline trachea, and this is important as we'll see coming soon. They have distant heart and breath sounds um, because of the air getting in the way of their lung sounds and the heart sounds if it's like close to the heart. They'll have hyper resonant chest percussion just because the air in there is like a drum. The management of someone who comes into the ED with a pneumothorax, if it's a small one, it's just conservative with supplemental oxygen and serial exams. Um, this isn't adult medicine, but like in my experience, I was in the NICU and there was a newborn baby who came into the NICU because they had bilateral pneumothoraces. And so they were born with these pneumothoraces, but we didn't need to do anything crazy. We just put them on oxygen. And after like a couple of hours, we just put them to room air and just got like a bunch of subsequent chest x-rays. They were small enough to the point where we could just observe for like them to spontaneously close. We didn't need to do anything crazy. Um, Conversely, if it's a large pneumothorax, um, that's an indication for a chest tube or a tube thoracostomy is like how it'll be described in like the answer choices on shelves or step. The way that you can differentiate if like something is small or if it's large, um, I guess by size, like if you do an upright AP chest X-ray, classically, I think the criteria is like if there's a distance at least 3 centimeters from the apex of the lung to the chest wall, then that's like an indication for a tube thoracostomy. Or hypothetically, like if you get a chest X-ray on someone who comes in with a pneumothorax and then you get a subsequent chest X-ray and it keeps getting bigger, then you would want to possibly go down the route of putting a tube in. Um, let's say you get this patient stabilized, you put the tube in, or you just watch them and they go home and it's fine, and then they come back again and again and again with recurrent spontaneous pneumothoraces. So there's like no chest trauma, but they still have these pneumothoraces. Um, in that case, I've seen you want to consider doing something called a talc pleurodesis, which is where you go in and essentially put glue between the edge of the pulmonary or the lung parenchyma and the chest wall to basically prevent it from like collapsing down. But like sometimes you'll see like a really big pneumothorax or something, and then it's like, which of the following is the next best step in management? And then they'll say like talc pleurodesis. You don't need to do talc pleurodesis for like one episode of a pneumothorax, but like this is more in the setting of recurrent spontaneous pneumothoraces. Okay, here's another chest X-ray. It looks a little bit different from the last one. Um, Here's the vignette. Patient comes into the ED after a high-speed motor vehicle collision. Patient was unrestrained. Surprise, surprise. Temperature is 37.5. Heart rate is 150. Blood pressure is 50 over palpable, which is not good. Respiratory rate is 30. They're in respiratory distress. The trachea is deviated to the left. So I told you this detail would come back. Jugular venous distension is elevated. Breath sounds are absent on the right. Chest X-ray is shown. And here's the chest X-ray. What is the diagnosis? This is a tension pneumothorax. Um, what is the next step in management of a tension pneumothorax? Immediately, you get a needle decompression and then you place a chest tube. So you will see on shelf or step questions, you'll see something that's consistent with a tension pneumothorax, and you'll see in the options a needle decompression and like a different option is to place a chest tube. You want to do the needle decompression first, and then you place a chest tube. Another thing that's important to know for tension pneumothorax is you can diagnose it clinically. Like you do not need to get a chest X-ray to make a diagnosis of a tension pneumothorax. So on a hypothetical shelf or step question, one of the options for something that is very clearly tension pneumothorax, one of the options for management would be like a chest X-ray. You don't need to get a chest X-ray if it's clear enough that they have tension pneumothorax. Um, so the signs of the tension pneumothorax, um, in this case, they're tachycardic, they're hypotensive. So like, if we can kind of make a comparison between a tension pneumothorax and pericardial tamponade with regards to how the heart functions, because in a tension pneumothorax, there's enough air that has entered the pleural space to cause like compression of everything else in the chest. That includes the other lung, and it also includes the heart and the because of the compression of the heart, again, just like in pericardial tamponade, preload decreases and therefore cardiac output decreases and blood pressure decreases, which is why we get the 50 over palpable blood pressure. And then because of the decreased blood pressure, heart rate is stimulated to increase, so they become tachycardic. Some of the other signs that are consistent with attention pneumothorax is the question will tell you that the trachea is deviated to the left. So just like the heart being shifted over, the trachea is also shifted over because of this air that's occupying the pleural space. And you can see the tracheal deviation clinically, and they'll also describe it in the vignette on the test question. Um, JVD is elevated because of the compressed head and neck veins, and also like impaired venous return to the heart because, again, of compression. So you'll see elevated JVD, and then you'll have the absent breath sounds because it's just air instead of lungs. Um, and then if the NBME is kind, they'll show you a chest X-ray. But again, you do not need to get a chest X-ray to make a diagnosis and manage a tension pneumothorax. All right, surprise, surprise. Here's another chest X-ray. Here's the vignette. Patient comes into the ED after being stabbed in the chest. Temperature is 37.5, heart rate's 110, blood pressure is 130 over 85, respiratory rate is 26. The patient is in pain and they are in respiratory distress. The trachea is midline. The left lung base is dull to percussion and has decreased breath sounds. You get a chest X-ray and it shows this. I was trying to find a chest X-ray that didn't have this like massive arrow, but this was the best picture that I could find. Um, we'll go over the chest X-ray in a second. What is the diagnosis? This is a hemothorax. So unlike a pneumothorax, in which case there was air occupying the pleural space, this is a hemothorax in which blood is occupying the pleural space and causing some lung to consolidate down. Before I get to management, I'll talk about like the clinical features. Um, they're like vitally stable. They might be tachycardic. They might be hypertensive because they're in pain. Their respiratory rate will be increased. They'll be in respiratory distress. Trachea is midline because it's not a tension pneumothorax. And I personally haven't come across any questions that talk about like a tension hemothorax, so don't worry about that. But trachea is midline, which makes you think less about a tension pneumothorax. In a hemothorax, unlike a pneumothorax, the lung base will be dull to percussion, whereas in a pneumothorax, you'll have hyperresonant to percussion. But in both cases, you'll hear decreased breath sounds. And then if you look on the chest X-ray, well, here's the arrow, but obviously you can tell that the diaphragm, isn't one side of the lung is much smaller than the other side, or one lung is smaller than the other lung, but there's also like this radiodense or radiopaque segment that has like what looks like a fluid meniscus in the left uh, chest, and that's just because the fluid, in this case, the blood, has accumulated in the pleural space, and you can see it on the chest X-ray here. So it might also be described to you as like a blunted diaphragm or costophrenic angle. So like if you look at the chest X-ray, the right lung has a very clear costophrenic angle, or like the angle between the diaphragm and the rib cage. That's a very clear angle, whereas in this case, it's just like this meniscus. There's not a clear costophrenic angle because the fluid has gotten in the way. The management of someone that comes in with a hemothorax, this is an indication to just go in with a chest tube. Let's say, for example, you go in with the chest tube, and as soon as you drain the chest tube, it immediately drains 2 liters of blood. Um, in this case, the question will ask you, like, which of the following structures have been injured? Or it might ask you, like, what do you do to manage this? Um, This is an indication that an intercostal artery has been lacerated. And this is an indication for surgery. So I think this is like the first time that we're sending someone to the OR for chest trauma. And we're talking about a surgery shelf. So look at that. Anyway, indications for or that are showing an intercostal artery laceration um, are if you place a chest tube and it drains at least 1500 mils, or if it drains at least 600 mils over the course of the first 6 hours after insertion, or if you simplify it, 100 mils per hour for the first 6 hours. Um, I don't think they'll get this specific, but like VATS or video assisted thoracoscopic surgery to go in and like close off or or not lacerate, ligate whatever artery is bleeding. But ultimately, this is an indication for surgery. Okay. I think hopefully we're coming up on the end of chest stuff. Anyway, here's another chest x-ray. Person comes in, high speed MVC, motor vehicle collision, chest hit the dashboard. They have rib fractures, which we went over. They also have altered mental status, and then their vitals are significant for tachycardia and hypotension. Um, a chest x-ray shows a wide mediastinum. And if you look on this chest x-ray, the wide mediastinum, I think of it as like instead of like the cardiac silhouette being the only significant radiopaque thing, there's like this radiopaque rectangle that's like sitting on top of the cardiac silhouette. So you can very clearly see this like rectangle. So that's a wide mediastinum. And then they measured it as well. I don't really know how severe that is, but the most important thing that I look at is this like rectangle. Anyway, so high-speed MVC, chest at the dashboard, rib fractures, altered mental status, tachycardia, hypotension, wide mediastinum. What is the diagnosis? This is a traumatic aortic rupture, which is basically like the aortic arch, while it's coursing in the mediastinum because of the trauma, has been ruptured. And so now blood is going into the mediastinum, which you can see on the chest x-ray showing a wide mediastinum. How do you manage a traumatic aortic rupture? Yeah, take them to the OR. This is another indication for taking someone to the emergence or to the for surgery. Um, Another thing that I'll say about this, rib fractures, particularly things like flail chest. If someone comes in with a flail chest or like really bad chest injuries or like ecchymosis to the chest wall, um, you want to keep your head on a swivel for something like a traumatic aortic rupture. Like again, if they have a flail chest, that usually requires high enough trauma to the point where it's enough trauma to cause a traumatic aortic rupture. So keep your head on a swivel for that. Um, and some of those signs that you can tell are the tachycardia, the hypotension, because of the blood loss into the mediastinum. The blood, again, as we've seen before, hypotensive, they're losing blood into the mediastinum. And so then the amount of blood in systemic circulation goes down. Therefore, they're hypotensive. And because they're hypotensive, that stimulates heart rate to increase. They become tachycardic. And then you also see the imaging findings. So that's that. Um, Here's a very quick question. Baseball player, they get a line drive straight to the chest and they die on the field on the spot. Um, they do an autopsy and it shows no gross structural damage to the heart or like great vessels or anything like that. What is the diagnosis or what happened in this case? This is commotio cordis, which is basically like in this case, the baseball player, they get the baseball straight to the chest right at like the wrong time during the cardiac cycle, and that causes like a fatal arrhythmia. So no gross structural damage to the heart, but it was hit at like the wrong time during the electrical cardiac cycle to cause a fatal arrhythmia and ultimately kill the athlete or whoever sustained the trauma. Okay. Um, we are now transitioning from the chest to the abdomen. So we are now going below the diaphragm. Um, Here's a chest x-ray, or I guess chest abdomen x-ray. Patient comes into the ED after a high-speed MVC. They were unrestrained. Um, Temperature's 37.5, heart rate's 121, blood pressure 130 over 85, respiratory rate's 26. So they're stable, but they're a little tachypnic, and they're in respiratory distress. Trachea's midline. The left lung base is dull to percussion, and they have decreased breath sounds. And then you do a chest X-ray, and it shows this. What are you thinking about diagnosis? So before I show you the answer, you might be tempted to think, well, we were just talking about hemothorax, and a lot of this other stuff is pretty consistent with a hemothorax. But we were just talking about a hemothorax, so why would I talk about this again? Because it's not a hemothorax. If you look at the chest X-ray, um, if you remember when we were looking at the hemothorax, it had this like blunted costophrenic angle, and it was like this weird kind of radiopaque stuff. There's this weird thing here that's like superimposed on the cardiac silhouette. Um, this is actually the gastric bubble, which is associated with an acquired diaphragmatic hernia. So this is not a hemothorax, this is acquired diaphragmatic hernia, which is basically when abdominal contents, like the stomach or intestines, herniate through a small defect in the diaphragm and they go into the left chest. And because there's like abdominal contents, not contents like stomach acid or anything, it's just like the tissue or organs. Um, because that stuff is getting in the way, you'll have dull to percussion and you'll have decreased breath sounds. It's not air, so it's not going to be like hyperresonant. Um, what else was I going to say? So like this happens when there's enough trauma to the abdomen to cause like a really quick increase in the intra-abdominal pressure to the point where you have abdominal contents that go through this little defect in the diaphragm. Um, okay. What is the next step in management of someone with an acquired diaphragmatic hernia? Surgery. This is an indication for surgery. Um, you will also see like newborns that are either born and then subsequently diagnosed with a congenital diaphragmatic hernia, which looks very similar to this, but it's just atraumatic, or it's like picked up in utero before the kid is born. And I plan on talking about that in my one of my subsequent peds episodes, but I'll describe it very quickly here since we were talking about acquired diaphragmatic hernias. Um, Not only do you worry about the abdominal contents being in the wrong spot, but in the baby particularly, if this happened early enough during development, it can cause pulmonary hypoplasia. Um, and so the management of someone or of a newborn that has a congenital diaphragmatic hernia is you intubate them, you wait for the lungs to mature, and then you operate. So intubate, well, okay, you intubate them, you sedate them, and then you wait for the lungs to mature, and then you operate. So lots of eights. Intubate, sedate, wait, and then operate is how I remember it. But that'll come up in another episode, like a dedicated slide. So don't worry. Okay, more abdominal trauma stuff. This is like extraordinarily high yield, and I'm kind of ashamed that I'm waiting until now to go over it, but I promise this is like, if there's one thing to take away from this episode, it's this. What are indications to do an exploratory laparotomy or an XLAP? Um, if someone is hemodynamically unstable in the setting of abdominal trauma, it's if they're hemodynamically unstable, so like hypotensive tachycardic. If they are peritonitic, so on physical exam, their abdomen is board-like, rigid, diffusely tender with rebound. Those are like, that's it. Like if they have any one of these features, you go into surgery and you see whatever is there and you fix it. Another thing that's really high yield for abdominal trauma is when to do a fast exam, when to do an abdominal CT exam. In the setting of blunt abdominal trauma. So the first thing you want to do is you want to assess if they're stable or if they're unstable. Um, so I'll first go over the algorithm for someone who is unstable. If they are unstable, you assess to see if they're peritonitic. If they're peritonitic, you do an XLAB. Like that's it. If they are not peritonitic, you do a fast. Um, and that is the fast is good and very quick at detecting free fluid in the abdomen. So that, one of those things for free fluid could be um, blood, or it could be like gastric or intestinal contents from a perf. In any case, if you do a fast and the fast is positive, as in they have free fluid in the abdomen, you go in for an X-lap and they're unstable, right? This is all in the setting of someone who's unstable. Um, if the fast is negative, you give them fluids and then you get a CT. Because like if the fast is negative, they're still unstable, but like you don't know where the injury is, so you give them fluids to stabilize them. Um, and then you do a CT. I should also say this is not like you don't want to wait for someone to get fluids if they're unstable, right? Like if they come into the emergency room after getting a trauma and they're unstable, before you start doing all this assessment stuff, you also like, you follow the A, B, C, D, E stuff, so like airway, breathing, circulation, disability, environment, stuff, stuff like that, which is which is important to know for like your rotations, but not necessarily for shelf and step, which is ultimately the scope of this series. Um, but all of that is to say, like, if someone comes in and they're unstable, you don't want to wait to start fluids on them. Like you would be giving them fluids. But in any case, if the fast is negative, you do a CT. If the CT is positive, you go in for an X-lap. If the CT is negative, you want to do close observation, and you also want to look for other sources of like bleeding, because if they're unstable, it means that they're bleeding somewhere. Um, and because you've already done the fast and you've done the CT at this point, and you've ruled out an intra-abdominal hemorrhage, you want to see if there's blood going somewhere else. Um, what else did I want to say? I think that's it for this. Okay. How does the algorithm work for someone who comes in hemodynamically stable? Um, if they're peritonitic, again, you get an X-lap. The difference is if they're not peritonitic, uh, you still follow the step of getting it fast. But the difference is if they're unstable and you do a fast, you go straight to an X-lap. If they're stable and their fast is positive, you get a CT scan. I'm just now realizing I never said what the FAST actually stands for. FAST means like focused assessment. Oh shoot. I ironically can't remember what FAST stands for. It's like, oh wait, it's like focused assessment with sonography for trauma, is what FAST stands for. But it's an ultrasound of the abdomen and like it's like an ultrasound of the heart, abdomen, and pelvis to see if there's free fluid in the abdomen. Anyway, so if they're stable and you get a FAST and it's positive, you get a CT. If the FAST is negative, you also get a CT. So it's kind of weird that like after regardless of the fast results, you get a CT, but this is how the algorithm works. Um, if the CT is positive, you consider surgery based on the findings. If the CT is negative, again, you do close observation. Um, okay, so I th yeah, that's all I wanted to say for this. And we will talk about like unstable versus stable in this segment, which is shock. So there are a couple of vignettes that I'll go over for like the different kinds of shock. So let's say, for example, someone comes in, they had a traumatic injury, they are hypotensive and they're bradycardic and they have numbness and weakness. Um, this bradycardia is a little weird, right? Because like if they have trauma, you would expect them to be tachycardic, but they're not, they're bradycardic. So what's going on? This is vasomotor shock in the setting of like a spinal cord injury, because well, the etiology is there's a high spinal cord injury, which results in a loss of sympathetic tone to the heart and vasculature. So you get vasodilation and bradycardia. So the bradycardia is explained. And then because of the bradycardia and because of the vasodilation, you have hypotension. How do you manage someone who is in neurogenic shock? You give them fluids, you give them atropine to restore the heart rate, and you give norepinephrine to restore vascular tone. How do you manage someone who comes in, or sorry, what's the kind of shock in someone who has a traumatic injury and then they come in and they're hypotensive and tachycardic? So this is what we were seeing with like the chest trauma and the abdominal trauma. What's going on? This is hypovolemic shock. So like hemorrhage. They're bleeding somewhere, and because their blood volume is down, they're hypotensive, and because they're hypotensive, they're tachycardic. What is the etiology? Well, I just said that they're losing blood. You also want to determine where this blood loss is happening. And so the mental, like the list of things that you want to keep in mind for blood loss that's enough to cause hypovolemic shock are if there are injuries to the chest, to the abdomen, to the pelvis, to the thighs, or to the external environment. So like if there's blood, if there's an internal bleed, chest, abdomen, pelvis, and thighs, those are the places where you can lose enough blood to cause hypovolemic shock. Specifically, you do not see the head or like a brain bleed. That's not a spot where you can have hemorrhagic shock. So don't get confused if someone comes in and they had trauma and they're hypotensive and tachycardic, and you're thinking that that's not because they're bleeding into their brain. It's because they're either bleeding into the chest, abdomen, pelvis, thighs, or into the external environment. How do you manage someone that has hypovolemic shock? Again, fluids. You find and stop the bleed, and then the specific management of the bleed depends on where the bleed is. Um, okay, some more shock stuff. You'll also want to know features of sepsis or septic shock. I'll just list them all out here. So if they have a temperature colder than 36 or hotter than 38, if their heart rate is above 90, if their respiratory rate is above 20, and or if their PaCO2 is less than 32. So a normal PaCO2 is like 35 to 45. If their PaCO2 is lower than 32, which it happens like because they're hyperventilating, so they'd have an elevated respiratory rate. Um, so you assess that with this. Or if their white blood cell count is less than 4, or if it's greater than 12, and or if they have at least 10% bands on a CBC with diff. You need at least two of these temperature, heart rate, respiratory rate, white blood cell count features to like really start thinking about sepsis or septic shock. Septic shock being they're meeting the criteria for sepsis, and they're also like um, tachycardic and hypotensive. So that's how you make the difference between sepsis and septic shock. Um, because notice, like in these criteria, blood pressure doesn't show up because that's how you make the diagnosis of that contributes to the diagnosis of septic shock. Ultimately, the way that I remember these features is throw, so like temperature, heart rate, respiratory rate, and white blood cell count. And then you just have to remember the numbers. One other thing in peds, if they have an increasing or a decreasing platelet count, that's another thing that can kind of tip you off towards sepsis or septic shock. And then, of course, once you make the diagnosis of suspected sepsis or septic shock, this is like the clock starts ticking. Um, so immediately you get a blood culture. That's the first thing you do. And then you start antibiotics within 60 minutes of making like suspected diagnosis of sepsis. So you get the blood cultures and you want to start antibiotics like as soon as possible. Those antibiotics that you want to start include things like Vanc, Cefepime, Meropenem, Zosyn. So like the big guns. Um, you want to assess the amount of lactate that they have in the blood. Usually you get concerned if the lactate is above 4. And then you want to start fluids within 3 hours of making the diagnosis of sepsis. And so one of the attendings that I worked with during my surgery rotation gave me this mnemonic, which is just BALF, or like BALF is the order that you want to do things once you make a diagnosis of sepsis. Um, Another thing that's important to remember for septic shock or like sepsis, or just in any case of like hypovolemic shock or whatever it is, you start with fluids. So as we saw here, fluids within 3 hours. If the fluids aren't working, like they're still hypotensive, you add pressors like norepinephrine. And if those don't work and they're still hypotensive, that's when you want to start steroids. So fluids, pressures, and then steroids. Okay, we've made it to the end. This was a very long episode. So if you made it all the way to the end, I commend you. Congratulations for surviving this episode. Um, as always, if you guys have any feedback on how I can make this better for you all, or if you have any suggestions for like specific concepts that you would want me to go over, I'm always open to your feedback. Leave me a comment, or however else you want to send me feedback. I would greatly appreciate it. So, best of luck with your studies for shelves or step two. If you're on your rotations, have fun on your rotations. Yada yada yada. I've talked way too much. You guys deserve a break. So, thank you all so much.